It's going to take about 12 and a half minutes, so I'm going to move kind of fast as I go through this. But the first thing I'd like to do is just sort of thank the host of people, I guess the village, that's been kind of instrumental in getting this to where we're at in year one. I hope they stick with me for the next couple of years. Really brief background about kind of what's occurring. And most of you are probably aware of the fact that there's been a dramatic rise, that the dramatic rise in opioid prescribing has been associated with several adverse related outcomes, things like overdose deaths and opioid use disorders. And one of the challenges, there's actually great medications for opioid use disorder. However, access to treatment is often a problem, and as a result, these medications are often underutilized. So to give you some context, in fiscal year 18, 42% of VA patients with an outpatient OUD diagnosis received medication treatment for opioid use disorder. And so when we typically talk about MOUD, we're talking about medications like methadone, buprenorphine, and injectable naltrexone. For the purposes of this presentation, though, I'm going to really just focus on buprenorphine. And then the thing to note about that medication is that to prescribe it, you need to have a waiver from the DEA. And then lastly, there are lots of initiatives right now in the VA to improve access to MOUD. This is just one of those. It's referred to as the Step Care for Opioid Use Disorder Train the Trainer. It's also known as the SCOUT initiative, which is designed to improve access to MOUD in clinics where veterans receive the majority of their care. These are typically pain management, general mental health, and primary care clinics. SCOUT's sponsored by the VA Office of Mental Health and Suicide Prevention, and they're using a train-the-trainer approach to spread these delivery models. And this is essentially where providers are trained to deliver a particular model, and then they become responsible for training others to deliver the same model. SCOUT was launched in an in-person two-day meeting that occurred in August of 2018. It was designed to train interdisciplinary implementation teams to deliver one or two models, the office-based opioid treatment model or the Massachusetts nurse care manager model. There were lots of things that took place in those two-day trainings, but the one thing to note is that the teams actually, most of them started to formulate their site's implementation plan at that meeting. And in year one, there are two implementation goals. The first is to implement MOUD in one of those three implementation clinics that were on the previous slide. And then in that same year to also spread that delivery model to one other implementation clinic at the same facility. It's also important to note that there are several external facilitation activities that are taking place, and they've been occurring since SCOUT was launched. These activities are coordinated and led by an external facilitation team, one of whom is actually here today, Dr. Hildy Hagedorn. And there are various sort of activities that take place. I'm not going to go through all those, but anything from monthly training webinars to community of practice calls, audit feedback, and site visits, to name just a few. So for the purposes of this presentation, the evaluation objectives are to describe buprenorphine prescribing outcomes and key implementation barriers and facilitators over the first 12 months. And I should say that these results are preliminary at this point. So this is actually a prospective quality improvement project. It's across 18 settings. There's one implementation team at each of the 18 facilities, and one of those facilities is located in each of the 18 VISNs. Our data sources include the corporate data warehouses, which is where we're getting the prescribing data for this presentation. And then for the barriers and facilitators, there's actually three different data sources. We administered a baseline survey to obtain implementation team members' initial perspectives on providing opioid use disorder treatment, as well as their clinic receptivity and some of the anticipated barriers and facilitators. And we also have access to ongoing documentation by the external facilitation team as they contact all of the sites or the facilities. And then we're conducting semi-structured interviews with the external facilitation team after they complete each site visit. So for prescribing outcomes, we're going to look at sort of categorized by patient and by provider. So for patients, we're looking at the number of patients with an opioid use disorder who were prescribed buprenorphine, and then also the percent of patients who started treatment and received at least 90 or more days of buprenorphine. So it's a retention metric of sorts. And then for providers, we're looking at the number of providers who prescribe buprenorphine to patients with an opioid use disorder. And then lastly, with regards to barriers and facilitators, we identified the key findings from each of the data sources, and then we triangulated the data to identify findings that had support in more than one of the data sources. So on to the results. So what you're seeing here are essentially just sort of a distribution of clinic types that these facilities actually have targeted over the first year. So as you can see, the primary clinic type is primary care, or the most common is primary care, followed by pain management and general mental health. There are 2 PCMHI clinics that were included in here too as well. I'm not exactly sure why. Those weren't initially targeted. And just to step back and orient you to the slide a little bit. So what you're looking at are the 12 months before Scout was launched and the 12 months after Scout was launched. That vertical line in the middle represents when Scout was officially launched, and that sort of corresponds to that 2-day training in August. The blue bars represent the number of patients receiving buprenorphine and who had an opioid use disorder, whereas the red are the number of providers who prescribed buprenorphine to patients with an opioid use disorder. And if you focus on the fiscal year 18 quarter 4 and compare that to fiscal year 19 quarter 4, what you're seeing is essentially almost a doubling in the number of patients receiving and the number of providers prescribing buprenorphine. And then in this first year, on average, 68% of the patients who initiate treatment are receiving 90 or more days supply of buprenorphine. I'm not going to spend a lot of time on this slide. I think mostly it's just sort of look and notice that there's likely some variation in these clinical outcomes by facility type, by clinic type. And the one that's sort of most noteworthy is the general mental health clinics, where as you can see, it looks like many of them had actually started to implement buprenorphine prior to Scout actually even launching. So with regards to key barriers and facilitators, so our survey was sent out early on to each of the team members. Our response rate was about 57%. We had access to 127 facilitation contacts and 4 semi-structured interviews with the facilitators. And these data, analysis of these data sort of identified 4 general themes. The first one being sort of a lack of buy-in or engagement of other clinic providers. So these are not the implementation team providers, these are their colleagues at their clinic. And very early on, you could sort of see that respondents to the survey sort of anticipated that there were going to be issues when only about half agreed that their staff members or their colleagues wanted to prescribe MOUD and that they were receptive to changes in clinical processes. One of the other sort of barriers that appeared from these analyses is that there does appear to be some stigma and or sort of discomfort of working with patients with an opioid use disorder, and that's across almost a majority of the sites. There are 2 facilitators that seem to sort of mitigate this to some extent. There were 4 sites that actually provided performance incentives to their prescribers to obtain a DEA waiver and to actually prescribe. And then there does seem to be a bit of a signal for when the facilitators do a site visit, there's oftentimes a DEA waiver training that they do. Thank you. And it appears that that is another way to engage some of these other providers at these clinics. And what you're going to see next is just a quote from a facilitator interview giving you some sense of the discomfort that some of these providers are experiencing. So other providers who are either waivered and not prescribing or haven't gotten a waiver yet, I don't know that the comfort level is there yet. I think there is still a sense that this should be treated in a substance use disorder clinic or that these patients are too complex. Another really significant barrier that sort of plagued this initiative, at least at some of the sites, is just credentialing and privileging issues. Again, this was sort of anticipated early on when respondents reported that they would like help or need help supporting the credentialing waiver prescriber process. And as you can see there, a majority of the sites actually had local credentialing issues. And I should note that those delay progress at many of the sites, but there are some sites where it's actually just thwarted any progress at all. And then this is just another nice quote from the facilitators that sort of indicate just how important the credentialing and privileging issue can be. The whole credentialing and privileging process, where some facilities require you to become completely re-credentialed once you get your X waiver, is time consuming. Another sort of category or sort of theme was a lack of leadership support. That too was sort of identified early on by the respondents to the survey, when less than half actually agreed that their leadership was good at promoting team building to solve clinical care problems or holding staff accountable for achieving results. And you can see there too that there was several sites that actually were sort of endorsed that they were having some leadership buy-in or turnover of leadership, which meant they had to go in and get buy-in again. A little context for this quote. So this is actually a response from one of the facilitators and really sort of describing what worked well at a particular site and how they were making progress. And one of the things that they sort of noted first was, one is leadership buy-in. To start, these two clinics spent a lot of time with their leaders, either at the mental health level or primary care. They had to get leadership to say, yes, go ahead and prescribe. And then the last sort of theme was sort of a lack of resources. It runs the gamut, everything from just feeling overburdened and too much too many competing demands to just not having enough protected time, and in one case, not having space to even see patients. Despite all that, and these are pretty universal across most of the sites, one sort of facilitator that did sort of rise to the surface that suggested how a lot of progress was made at many sites, and that was having highly motivated providers and clinical champions. And this next quote just describes this really nicely. So these are clinicians who are going above and beyond. They are not just seeing their patients, but then they are maybe consulting with another provider who had trouble, or they are talking to leadership. They grab the bull by the horns and they are off to the races because they believe in it and they've decided that they're going to make this work. So lastly, conclusions. SCOUT appears to have increased the number of patients receiving and the number of providers prescribing buprenorphine in implementation clinics in year one. However, there are a couple qualifiers to that. There's probably some variation among the clinic types, and these are also unadjusted, sort of uncontrolled for analyses, and we'll have to do some additional sort of more rigorous approaches to truly test that out. Key factors facilitating efforts include highly motivated champions and providers and facilitator-led DEA waiver trainings. Credentialing and privileging was a big issue, and again, it not only delays progress, but it also in some cases just thwarts progress completely. And then lastly, there are several limitations to this project. Just a few that we have a small number of interviews with facilitators to date. There's certainly potential issues with response bias. And then our perspectives from providers have really only been obtained at baseline, at least so far. So we're trying to rectify that right now. We actually have a series of ongoing semi-structured interviews with providers and champions at all 18 sites. And we're planning to do or to use sort of a more sophisticated analytic approach going forward. And with that, I just want to thank HSR&D and Query for funding this project, as well as the Office of Mental Health and Suicide Prevention for being excellent partners. And with that, I thank you.
We have time for a question or two.
Eric Goldbecker from VA Connect. A really nice presentation. I was struck to see the number of patients highest in pain clinics. Did any of the qualitative, I mean, that's just from where I sit, would we expect, all of our efforts have been in primary care, and then of course we hope that's for general mental health. Anyway.
Yeah.
Anything to comment on that?
I don't have any really good data to support what's going on there. There's clearly something going on. If I can, a couple hunches. One is that I'm wondering if they have smaller caseloads and that they might be better resourced as well. But outside of that, I don't have any sort of great ideas. I mean, it does appear though, if you want to do this quickly, that might be the clinic type that you want to start. What will be interesting to see is if they have some barriers, going forward. I mean, they are set up somewhat differently. Again, this is sort of based on anecdotal data. They tend to take their patients on for good. They don't transfer back to primary care, and I suspect that there might be some issues with plateauing out and just running out of bandwidth. That's a great question.
We're going to go and transition. And are we being live cast? So we are being live cast, and we'll go and transition. So this is just a reminder for all of us, to speakers, to go into the microphones, and in the future for questions, I'll go around with questions, so that way people that are coming in can actually hear what it is we're saying instead of an odd muffle.
Can I ask a quick follow-up? About the pain clinics? Like, did you see
repeat the question briefly.
Okay, so I guess if I understand the question is, did this seem to be unique at just a few of the pain clinic sites, or did we see that across most of them? Oh, I honestly don't know the answer to that question, so I'm hesitant to actually try to address that.
Thank you.
Okay.